aims to minimize the impact COVID-19 has on our health, our healthcare systems, and society, while also focusing on protecting those who are the most at risk of severe illness. The CDC analysis showed that their new COVID-19 community levels provides a sizable improvement over the community transmission levels that they had previously in identifying regions that will experience severe outcomes, including ICU admissions and deaths in the weeks ahead. These severe outcomes, which require so much time and care from our healthcare workers, are a major reason that our hospitals are getting overwhelmed. Previously, CDC's transmission levels only considered case rates and percent positivity. The new CDC COVID-19 community levels can inform local response efforts. When making decisions about prevention methods to reduce COVID-19's impact in their communities, state and local public health authorities should consider local factors and data sources, including the new levels that CDC provided and their underlying indicators, vaccination coverage, capacity for detecting new cases and novel variants, as well as local populations that are at risk for severe disease. CDC's new COVID-19 community levels assess data to calculate county-level measures that combine 3 measures taken from both public health data and hospital data. They consider weekly indicators of the proportion of hospital capacity devoted to caring for COVID-19 patients, and 2 rates, the rate of new COVID-19 cases in the county per 100,000 people, and the rate of new patients with COVID-19 admitted to the hospital in the past week per 100,000 people. The combination of these measures determine the COVID-19 community level in a county, and they rank them as low, medium, or high. At all levels, it's recommended to stay up to date on your COVID-19 vaccines and get tested if you have symptoms. If a COVID-19 community level is in low or classified as low on the map, CDC states that people, households, and communities can take minimal practical precautions. If the COVID community level is medium, CDC recommends focusing specific prevention measures on protecting those who are at increased risk of severe illness. And if the community level is high, CDC recommends layered prevention measures to avoid overwhelming local hospitals and healthcare systems by preventing severe illness and death. At the high level, for instance, CDC recommends that everyone in schools wear a mask indoors, and anyone who is at increased risk for severe illness should wear a mask or respirator that provides them with a greater protection, such as an N95 or a KN95 respirator or mask. Since the new guidance was just released a few days ago, we are still evaluating it. And as Idaho State Public Health Authority, we agree that we are entering into a new phase of the pandemic, as the director mentioned. And we need to start shifting our focus to a new emphasis on information that will help us better predict and prevent severe outcomes, such as hospitalizations and deaths, as I just mentioned, by informing the community and recommending preventive actions. The new CDC community levels will aid in those considerations. We do welcome, of course, CDC's interest in establishing community levels of risk to help standardize the way the community burden is measured across the country. We're also able to access and review the new CDC community levels indicators on Friday. But as I mentioned, we're still working with our federal partners. We're still looking at that information to really understand their calculation methods and obtain those calculation methods. We know that measures are often honed over time, and changes may be made in the future to these measures as they're tested out in the real world. We support these current recommendations linked to community levels as determined by CDC. We've also provided input on how CDC could help ensure those recommendations are easy for everyone to interpret and use. In closing, I'd like to emphasize that despite improvements in COVID cases and test positivity and hospitalizations in the past few weeks, we will, and despite what you will see with CDC's new community levels, if you look at those maps that they have available, some communities in Idaho continue to have high rates of illness and hospitalizations, and we really need to pay attention to those. We need to continue in those areas to take those preventive measures, such as getting vaccinated, wearing our masks when it's appropriate, and social distancing. Those are all still very helpful measures to continue to further reduce the impact of COVID-19 in the state. Just as a side note as well, we did learn from our CDC peers that they will be updating that information weekly, every Thursday. So we will continue to work with CDC to better understand their methodology, better be able to communicate any changes to you. And with that, Nikki, I'll turn it back to you and we can continue on.
Okay, thanks, Elke. So we'll now go ahead and take questions from the media. You guys pretty much know the drill, but please raise your hand in WebEx, or you can also type your question into the chat. When I say your name, go ahead and unmute yourself and announce your name and media outlet before asking your question, and then clear your hand when you're done. I think I saw Audrey Dutton's hand go up first, so we'll start off with Audrey.
Thank you. Good afternoon. This is Audrey Dutton from the Idaho Capital Sun. So I went through the CDC's community levels on Friday using the data that we had available at that point for the hospital data, as well as the case numbers and through the state. And I did it again yesterday, and they're not matching up with CDC's. And so I'm wondering if that's what you mean when you're trying to get clarity on how they did the calculations. I understand the hospital regionality of it. And so I followed the way that they did it with the hospitals, but I can't figure out why they're not matching up. And particularly Ada County's case numbers were way different, the per 100,000. So can you help at all with that?
Yeah, Audrey, those are great questions, great observations. And yes, so those are some of the things that we are trying to determine from CDC. But I have a feeling many of these questions today related to this are going to be fielded over to Dr. Turner and Dr. Hahn, who've been working on this a little bit more closely. So I'm going to turn this over to Dr. Turner.
Thanks, Elke. And Audrey, thanks for trying to ground truth the data. A couple things. The first thing to know is that CDC does what is called web scraping in order to get the case counts they're using. It is not data that we send them routine. They're actually going to our website and scraping data off of it. And what they do with it after that, I cannot speak to. The other thing that you should know is that although the two measures, the proportion of inpatients and the number of new admissions in hospitals we have, and it's raw data, CDC is doing some extrapolation based on health service area for the admission data, and then sort of extrapolating where the people in the hospital might be living depending on that health service area. And we don't have the methodology for that either. So while we trust, but we verify. So we are working with CDC to try to get a hold of those methods so that we can either duplicate what they're doing or help explain it a little bit better. Right now, it's sort of a black box, and we can't help answer your questions until we get their methods, but those are coming.
Okay, thank you. Yeah, just the Ada County in particular, the differences in the case numbers, the CDC had more than 1,000 per 100,000, but the Division of Public Health data has about 133 per 100,000, so it's quite a large discrepancy there.
Elke, do you mind?
Dr. Yep, go ahead.
Yeah, so one thing to keep in mind, Audrey, when you're looking at those data is we display the 7-day daily average. So it's how many cases in a single day on average. CDC is doing a weekly average. So it's for 7 days, not just one day. So there's going to be some differences there too.
Okay, thank you.
Sure.
Okay, our next question is going to come from Carolyn Kamatsoulis. And Carolyn, I'm sorry if I mispronounced your last name.
No, that was pretty good, actually. That's pretty close to what it is. Yeah, so good afternoon, guys. Obviously, this new CDC guidance is looking at sort of the burden on hospitals, and that's new. and several areas of the state, continue to have strained hospitals. I mean, what is it going to take in Idaho to lessen that burden on hospitals, and how long might that take?
Caroline, that's a great question. And what it will take to lessen the burden on hospitals is to lessen the burden of COVID in communities. We've talked about it on many, many calls over time that not only do hospitals get overwhelmed by patients themselves coming into the hospitals, but also by the impact that COVID's having on their staff, whether their staff are sick or their staff are home on isolation or their staff are home caring for someone who is sick. That's a huge impact on hospitals, and that the staff burden is a direct relationship to what's happening in communities. So as the burden of the disease goes down in communities, then we'll be able to see less strain and stress on the hospitals themselves. Of course, there are, we're doing everything we can to help support the hospitals, as we've talked about in the past, and helping them support staffing. But really the biggest driver are going to be getting our cases of severely ill individuals down and reducing the impact of COVID in communities. And Dr. Hunt, I'll turn it over to you to see if you have anything you'd like to add.
Yeah, thank you, Elke. Can you hear me okay?
Yes.
Okay. I just got this headset yesterday, so I am still a little unconfident. Yeah, just two quick things to add. One is, as I'm sure you've noticed on our dashboard, that hospital numbers are dropping, so we're really happy to see that. And in addition to a decreasing burden in the community in general, we know that the folks that end up in the hospital are folks either more elderly or with underlying health conditions. And to make sure that those folks are vaccinated, of course, we've been saying this for a long time, but we still remain at one of the lowest vaccination rates in the country. And we are concerned that we still have a lot of adults who are very vulnerable to COVID, and we will continue to see people coming into the hospital as long as COVID is around, which seems like is for the long term.
And with hospitalizations dropping, is there any indication of how long it would be before hospitals are like out of contingency standards?
Go ahead, Chris.
Yeah, I'll just say no. We don't exactly know. We continue to have regular calls with them. We continue to see little glimmers that things are getting better, and yet they are still stressed. And so we're hoping as these numbers start dropping down and as influenza also has been dropping, which is great because that's another thing that can really burden hospitals this time of year. So we're hopeful that we're coming around the bend here and things are getting better, but I wouldn't hazard a guess. And I don't know, Elke, if you or someone else would have more to add.
Nope, I wouldn't hazard a guess as well.
Thank you.
Okay, our next question is going to come from Jack Schemmel.
Hi, this is probably more of a generic question, but in southern Idaho, Magic Valley area, some of the incidence rates are very high, but as we've mentioned here, things are kind of slowing down around the area. Is the Magic Valley just late to the party in terms of when they hit their peak and when they're settling down, or is that an area of concern?
Yeah, thank you, Jack. And Dr. Turner, do you want to take that question?
Yeah, thanks, Elke. Yes, the rates in the Magic Valley area do seem to be not going down as fast as they are in the rest of the state. They seem to have plateaued a little bit and even maybe bumping up slightly day to day. We're not sure why that is, except that you'll probably remember that back in 2020, this was the area that was hit the hardest. I mean, had one of the highest rates in the entire United States back in spring of 2020. So it's likely that there some of that natural immunity that occurred during that time is waning, and we could be seeing some effects of that. But the case rates are definitely not decreasing in that area the same way they are in the rest of the state, and we're watching to see why that is, or whether or not they're going to start nudging down a little bit.
Does that concern you at all?
Go ahead.
Well, it always concerns me when One area of the state has case rates that are relatively higher than other areas of the state. We also have to remember that for our resort communities, sometimes that's a result of virus being brought in to people who are infected showing up within our communities. So our resort communities have always been just a little bit different than their surrounding communities, but it's something we watch really closely.
Thank you.
Okay, we'll move on to our next question, and that's going to come from Andrew Bartline.
Hey, Andrew at KTVB. I'm curious with all these CDC changes and sort of how we're evaluating numbers, what kind of value is put into just that raw case count that's getting recorded? And then, of course, there's that backlog as well. So how accurate are those numbers?
Great. Dr. Hahn, do you want to start, and then Dr. Turner finish up?
Sure. Yeah. Thank you. Yeah. Certainly the case counts are something that we eventually think we will move away from. We've been, I think, talking about this for a while, that like influenza, if this becomes a seasonal virus down the road, that we would probably move away from counting every case and really focus on the burden on hospitals, burden in the communities, outbreaks in congregate settings, that kind of thing. And I think this is the new CDC indicators are a step in that direction. As you've heard, they do continue to incorporate cases per 100,000 as part of what they're looking at, but starting to shift our attention to community burden as far as infrastructure. How are the hospitals doing? How's our healthcare systems holding up? I think that's the way that we're headed. Dr. Turner, I don't know if you have anything to add.
Yeah, thanks, Dr. I think the only thing I would add is that it's important to realize that our public health districts are keeping up with recent lab reports. So the current case rates are accurate. The backlog is for cases that were identified in mid to late January, right at the peak of that surge when things were so busy and they were getting so many lab reports, they just couldn't plow through them all within a day. So if you look on our dashboard, the case rates are pretty darn accurate because they're just based on the last 7 days of cases. It's a 7-day daily average. So just want to assure everybody that recent case rates are accurate on our dashboard.
And then just a quick follow-up. I don't know if I missed this earlier, but how are you feeling as a board about the current levels of COVID in Idaho? I know it's fluid. I know it changes. I know the way we're evaluating it is just kind of moving today with these CDC guidances, but are we feeling generally good about the direction we're at?
I think I'll start and use a phrase that I used maybe I think back last summer, cautiously optimistic that things are better. It feels better. Hospitals seem less stressed. Cases are going down. So it definitely feels better, but I use the caution piece in that we still have pockets, as was just brought up even for central Idaho. We've got our Southwest District, the District 5 area of the state, that we still have pockets where we need to be very cautious about what things are looking like. But I would say for me overall feeling much better, but I'm going to see if Dr. Hahn or the director have anything they'd like to add.
Director, I'll let you comment. I certainly agree with everything Elke said. We're happy to see the direction, but it's still too high. The case counts are still higher than we'd like to see. I don't know if you have anything else to add.
I'll just repeat, which is headed the right direction, but the numbers are still too high. Higher than we'd like to see.
Okay, we'll move on to our next question, which is going to come from Troy Oppie.
Good afternoon. This is Troy at Boise State Public Radio. Just looking, Dr. Turner, to some clarification on what you just said. The recent case counts on the 7-day rolling average are current. What about the daily new case counts? Do those numbers include newly processed tests from that backlog dating back to January or wherever that is in the process now? Or are those only the new cases of the day? Because that is not clear to me.
Dr. Turner, go ahead.
Thanks, Elke. Troy, the new cases added every day includes new cases for today and any backlog that has been processed. It's a cumulative. So we announce how many new cases have been submitted to the state every day. That's why we also provide the case rates. The case rate trend is because it is based on when that case was identified. So it's going to update backwards. The trend line will change, but as the current case rate that is displayed right now is pretty darn accurate because those lab reports are being processed within 24 hours.
Okay, thank you for that clarification. And then a follow-up to that would be, do you know which metric the CDC is using? Or they're using that 7-day rolling average that is more currently accurate?
Yeah, so Troy, they're as I mentioned, they're doing this thing called web scraping. So they go out to websites, and I'm gonna admit I don't exactly know if they're using AI for that or if it's like a person. And they're kind of scraping the counts off the dashboards. And I think, if I'm interpreting their data correctly without seeing their methods, that they are looking at the cases that were reported on a given day. So I don't think they're looking at the right data, but they should be pulling the data from our case rate dashboard. But I think they're pulling it from new cases submitted for the day, which would inflate all of our case rates in the new levels.
And I'm sorry, one more follow-up, if you'd permit me. It sounds like this change from the CDC and their methodology may not have been communicated ahead of time to health departments like yours. How much of a heads up did you get, and what's the timeline for when you're going to know some of these more detailed things, like, you know, which metric they're using?
I can say that we learned very shortly before it was released. I think there was some inkling of information happening before that, but it was in short order. I will put it that way. And then Kathy, or Dr. Turner, excuse me, I don't know if you have any insight on the potential of any change.
Thanks, Elke. I don't have a good sense of timing. The ask for the methodology started last week, and us and all of our colleagues across the United States are asking for the same thing. So I expect it will be in short order. I don't have a sense of when that might be.
Thank you.
Okay, we'll move on. We have another question from Audrey Dutton.
Yeah, I wanted to check in on the availability of the prophylactic medication and the Evusheld and monoclonal antibodies and Paxlovid. What are our distributions like on those now?
Thanks, Audrey. That is a Dr. Hahn question.
Yeah. Hey, thank you, Audrey, so much. We are actually, as you know, it's a ever-changing week by week situation, but we've been very happy that we have a new. I think we've announced it at our last press briefing. It's just a few weeks though, that we have a new monoclonal antibody for a few weeks, a long time. Everything feels longer than it is. For several weeks, we had only sotrovimab. And so for our monoclonal treatment antibodies, we now have a second one. So that supply is much better, and we are actually working with pharmacies to expand the number of, not pharmacies for these two particular drugs, but we are working with our treatment providers to try to encourage them to take more if they think they can use it. As far as our antivirals, those are also holding steady. And as case counts go down, as you can imagine, the demand is going down. So we're starting to feel like the folks that we're sending it to are saying that's enough. We're not using it as quickly as we used to. So we're offering it to more pharmacies so that it's more widely available. The third category, those preventive monoclonal antibodies, our cancer centers have told us they believe that they have enough to, they've vaccinated, I say vaccinated, it's loosely a vaccine, but they've administered this medication to most of their patients. They feel like they can, they don't need as much as they did initially to try to get their patient populations taken care of. So we are now expanding the number of providers also that will be offering those. So we're really pleased that right now, I think we've flipped from maybe 3-4 weeks ago, even still having a shortage of all three of those categories of product, to where we feel that we're now closer to being able to meet the needs out there, and now focusing more on making sure providers and patients are aware of this opportunity. As we've talked about, we struggled before with over-promising and not having enough for everybody, but now we feel like we are making it more widely available and are going to work try to make sure that the awareness is there. You may have heard that the preventive one, the FDA just doubled the dose. So one more change. They just doubled the dose. And so suddenly we have half as much effectively. But fortunately, because we have so many folks have already received treatment, and right now there's not a recommendation that they need to go and get a second dose or anything. So we think that we are, even with that double dose, which has cut back our effective supply, we think we're in okay shape for now. And we're actually starting to coordinate with Oregon and Washington as well, so that if they have some extra doses, we could potentially, or we can make sure they're getting used effectively.
Thank you.
Mm-hmm.
Okay, our next question is going to come from Ian Stevenson.
Thanks, Nikki. Ian Stevenson, Idaho Statesman. I have a two-part question, and apologies if this slipped by me in the earlier explanation. I realize you all are still gathering details on this, but is your understanding of the new CDC metrics that hospital admissions in rural parts of the state where COVID patients would be sent to places like the Treasure Valley if they require hospitalization, is the understanding that that is somehow being accounted for in the overall metric of how the risk is distributed by county? And then second, I wondered if you all have thoughts on how close the areas of Southwest Idaho that are in the high risk category are to falling out of that into the medium or low risk designation.
Great questions. Dr. Turner, do you want to tackle those questions?
Yeah, I'll try and then invite my colleagues to jump in. So Ian, I already forgot the first part of your question.
I was saying, I'm just wondering, with the metrics now include hospital admissions and new patients. So how does that accounted for with rural versus?
Yeah. So Ian, that's a great question, and it's the same question we are all asking right now. We don't have the methods that CDC is using to say that. So for all of the new admissions to say, hospital X, how many of those new admissions were residents of counties A, B, C, D, and E? We do not have that methodology of how they're extrapolating that, and that's really what we'd like to know. So, so that we can, like I said, I don't want to duplicate what they're doing, but it would be nice to be able to explain it in a way that's understandable to the entire public, and we just don't have that right now. The second part of your question, which was where are they now, and how close are they to getting like from high to medium and from medium to low? And unfortunately, since we don't have any way of knowing how they're, we don't have any way of looking at our raw data and being able to determine that because we don't have their methods. We just don't know yet.
Okay, thank you. I guess a follow-up to that might be, I'm curious what the channels of communication are like with the CDC. You mentioned that the data team seems to be pulling the wrong, the cumulative data versus the daily data, and therefore possibly inflating their numbers. Do you all have like points of contact at the CDC, or is it easy or difficult to get someone on the horn there if you think they're doing something incorrectly, or what's that sort of been like recently or over the past during the pandemic?
Well, I can start with that, Ian. I think all of us on the phone or on the video right now have our own connections with CDC. I know I get opportunities to listen to their presentations on things multiple times a week. We have opportunities through my national organization to have conversations with them. I can assure you that all states through our channels have been giving input, and I know that they're considering that. And then Dr. Turner and Dr. Hahn both have a national organization that they belong to that has some really, I think, more visibility into the people at CDC that do some of this work behind the scenes and have heard those messages. But when we will get that information back, I don't know. I think that's part of the, as Dr. Turner said a few minutes ago, we don't have direct line of sight on when we'll get that information back. But Kathy and Chris, if you have anything you want to add, please do.
I don't have
Yeah,
anything to add. I don't know if Dr. Hahn does.
Yeah,
Sorry.
I'll just support what was said. I think as you guys understand and have heard from us, while we really like where CDC is headed, we really want to be able to support, endorse, promote, and use this data with confidence. And we don't have the information we need yet because of some of the questions that many of you all have raised. And as we look at the map and look at our data, we want to make sure, first of all, that we understand what CDC has done, but secondly, that if they are doing something wrong, that there's a chance to correct it.
Okay, we'll move on to our next question, which is going to come from Kathy Hedberg.
Hi, this is Kathy Hedberg from the Lewiston Tribune. Can you hear me?
Yes, you're very faint.
Okay. All right. Okay, can you hear me now?
I think that's a little better.
So I have two questions. First of all, I'm wondering what the staffing, hospital staffing situation is like in the state, whether the Idaho National Guard are still being used anywhere. And my second question, I think for Mr. Jeppesen, we cover southeastern Washington as well as north central Idaho, and I've noticed that Washington's reporting and their website is changing. It's been changing in the last couple of days, I suppose, maybe since the CDC directive. I'm just wondering, are you planning any changes to your website anytime soon because of the new way you get information or for any other reason?
Yeah, Kathy, I can start in on the responses. So regarding hospital staffing, we do have hospitals across the state that continue to use the federal staffing resources through our contractor ACI. They submit requests for assistance on a regular basis, and we work, our department works very closely with the Idaho Office of Emergency Management to receive those requests and make those kind of allotments of staff, if you will, out into the hospitals and healthcare entities that need them. So that is ongoing, and as hospitals need, and hospitals and other healthcare entities need that, we will make it available as long as the federal emergency order supports the availability for that. Regarding the Idaho National Guard, to date, in this most recent deployment, they have been sent to 2 locations. They've been sent to help support the Department of Corrections and primary health here in more the Treasure Valley area, and those efforts are still ongoing. So yes, staffing resources are still out there. And regarding changes to the website, I had heard from my peers in the state of Washington that they are making changes directly as a result of the CDC information that's becoming available. And I would say that we need to, as we keep talking about, need to assess what's going on and how that might impact our website if we are going to make any changes. And I will let the director see if he wants to add anything, and if Dr. Turner wants to add anything about website changes.
The only thing I would just say is our goal is always to provide the most accurate information in the most understandable way possible. And just kudos to Dr. Turner and her team who have taken the lead on that and done a phenomenal job. When we started 2 years ago, we had exactly 0 web presence on reporting metrics around coronavirus, and we are pretty proud as to where we've come. that is likely to continue to evolve as the needs evolve, but I don't know of any major shift coming immediately. And with that, I'll hand it over to Dr. Turner to correct anything I've misstated there.
No corrections needed, Director. We're going to continue doing what we're doing because people are using the information, and that really is the key. We don't do it for us, we do it for you. And until we reach a point where we need to change how we're using the data, we wouldn't make any major changes to our dashboard.
Okay, we'll take another question from Audrey Dutton.
Thanks. This is kind of a big picture question. Now that we're approaching that 2-year mark since the first confirmed case, I wonder what, when you think back on kind of the early days, what you hope the state will take away from everything that we've learned over the last couple of years. One of the things that I've been thinking about as I've gone through some of the news stories from early on is that idea of worst case scenarios don't happen if preventive measures work. So people will say, hey, why did we do that? We didn't have the worst case scenario happen. So I'm just wondering kind of what, in an ideal world, what do you hope will happen when the next pandemic arrives? Like, how do you hope that people will respond, or the government, or anything like that?
I think that sounds like a great question for the director. I'm going to hand it over.
Thanks, Elke. And Audrey, that's actually an excellent question. We haven't quite gotten there yet, but we will actually do a review of how things have gone and and lessons learned and after action report. There's lots of words for that phrase. And when we do, we're happy to share what we think those are. I'm still pretty focused on this pandemic and making sure that we continue to provide the best information so people can make the best decisions to help them and those around them stay healthy. And so I think where we'll be focused is really how do we do that the best? What's the best way to provide information to individuals so that they can make decisions that put them in the best position to protect their health and to help those around them protect their health. And I think that has been one of our challenges through the pandemic. And I think that is one of the things we need to continue to work on and think through for both the rest of this pandemic and any other public health emergency that may come along. So it's a good question. We are slowly starting to think about those things, and probably as things transition to this next phase will give us time to really dig into that in detail.
When do you anticipate having that or performing that work?
Well, Elke, do you want to take that or you want me to?
Sure, go ahead, and I'll finish up after.
Okay, great. We'd actually like to, we obviously would like to start that as soon as possible. Just a few short weeks ago, we were in crisis standards of care. So we're trying to sort of come out of that and really adjust to this new phase. But, ideally, sometime over the next couple of months, we'd like to really dig into that in detail and really start to process what is it we've learned, what went well, which I think is a lot that's gone well, and what could we have done better. And there's definitely opportunities there as well. So, but Elke, I'll let you also chime in there.
Yep, I think the time frame that you laid out is appropriate, and I know I want to echo the fact that I think there have been a lot of things that have gone really well. We've learned a lot. We continue to learn a lot. We really need to, I think we don't take any of our recommendations and the advice that we're giving lightly. We know that it's very challenging as things are changing constantly. But we're always looking for the best available information possible and trying to share that with you. And as the director said, helping people make the choices that can keep them and people around them the healthiest. And so we know that some of it's been challenging. Some of it's been fraught with a lot of uncertainty, but we know that based upon the science that's available to us and the experts that we have in our ranks here, that we're making the best possible decisions we can for everybody in the community in Idaho. So more to come. I think, as the director said, the next couple of months we'll have more lessons learned. We have, of course, some requirements from CDC, from some of our funding sources about types of reports that we have to submit. But I think even looking at the broader picture of kind of telling the story and capturing the narrative of how things have gone is really important. So more to come.
Thank you very much.
Okay, I am not seeing any more hands. Although Audrey, you still have your hand up. Did you have another question? Oh, nope. Okay. All right. Well, seeing no more questions, we'll go ahead and wrap it up for today. Our next media briefing will be on March 15th at 2:30 p.m. So we're on an every other week schedule for now. Thank you for joining us today.